Welcome to this explainer. I am absolutely thrilled you're joining me today. We're going to take what is widely considered a really complex kidney disease, IgA nephropathy, and translate it into clear, totally digestible concepts. So whether you're dealing with this in a clinical setting or you're just a focused learner who wants to understand the cutting edge of nephrology, my goal today is to give you a highly structured roadmap. We're going to cover exactly what this disease is, how it behaves, and honestly, the most exciting part, how we are finally learning to defeat it. Just to give you an idea of why we're focusing on this topic today, consider this massive statistic. 40%. That is the proportion of primary glomerulonephritis biopsies in East and South Asia that come back as IgA nephropathy. It's actually the most common primary glomerular disease in the world. So this isn't just some rare textbook anomaly we're talking about. This is a massive global health burden causing serious kidney damage for literally millions of people. To really get a grip on a disease of this magnitude, here is our roadmap for today. We'll start with the global kidney burden, unpack the four-hit hypothesis, spot the clinical clues, decode that MESTC biopsy score, review conventional management, and finally, dive into the thrilling new treatment frontiers.
All right, let's jump straight into Section 1, the global kidney burden, which truly is a worldwide challenge.
While that 40% stat highlights a massive impact in Asia, make no mistake, this disease does not respect borders. What's really fascinating is who exactly is in the crosshairs here. It primarily strikes young people. The peak incidence hits right in the second and third decades of life. It also has a really strong gender lean, affecting men at twice the rate of women. Over in Europe, we see it accounting for a full 20 to 25% of biopsy registries, which is huge. But perhaps the most alarming detail? In regions like South Asia, it is highly underdiagnosed. The true prevalence is probably way higher, but limited access to advanced kidney biopsies just keeps those cases hidden from the official registries.
Moving on to Section 2, pathogenesis and the four-hit hypothesis.
Okay, so before we get to the four hits, we need to meet our main culprit. It's called galactose-deficient IgA1. I know, it sounds like a mouthful, but in easy English, it's basically just a defective version of a really common antibody in your immune system. Specifically, it's missing a tiny sugar molecule called galactose. Because it's built wrong, your body doesn't quite know what to do with it, and this rogue protein acts as the central driver for the entire disease process.
So, how does this rogue protein actually cause the damage? Well, it triggers a biological domino effect that we call the four-hit hypothesis. Hit 1. Your mucosal immune system, think your gut or your tonsils, overproduces that abnormal, sugar-deficient IgA1. Hit 2. Your body's own immune system realizes something is wrong and pumps out autoantibodies to attack it. Hit 3. Those antibodies lock onto the abnormal IgA1, forming these huge, clumpy immune complexes that just circulate in your blood. And finally, hit 4. These big clumps travel to the kidneys and get physically stuck in the delicate filters, called the mesangium. This kicks off a massive, localized inflammatory response that damages the tissue. It's essentially a microscopic traffic jam in your body's filtration system.
All right, Section 3, spotting clinical clues. So how does that microscopic traffic jam actually show up in a living, breathing patient? It's kind of a tale of two presentations. On one side, we have synthpharyngitic hematuria. This is the dramatic one. A young patient gets a sore throat or respiratory infection, and literally within a day or two, they have visible, dark blood in their urine. It's an obvious red alert symptom. But contrast that with the other side, asymptomatic microscopic hematuria. This is way more common, and honestly way more sneaky. The patient feels totally fine, their urine looks perfectly normal to the naked eye, and the only clinical clue is invisible red blood cells picked up on a routine lab test. Oh, and here's a great clinical pearl. Routine blood work usually shows totally normal complement levels, which really helps doctors distinguish this from other kidney diseases. Now, while that microscopic blood is common and usually pretty slow-moving, it's vital to remember there is a severe end to this clinical spectrum. Some patients present with nephrotic syndrome. We're talking massive protein leaks causing severe swelling, or rapidly progressive glomerulonephritis, where kidney function just plummets in a matter of weeks due to intense inflammation. These rare presentations are absolute renal emergencies. They require immediate, heavy-hitting immunosuppression.
Let's jump to Section 4, the MESC biopsy score, which is essentially our medical forensics.
Because clinical symptoms vary so wildly, you simply cannot officially diagnose IgA nephropathy with just a blood or urine test. The absolute gold standard is a renal biopsy. A nephrologist actually has to extract a tiny piece of the kidney tissue, stain it, and look at it under a microscope. We are specifically hunting for those clumpy IgA immune complexes gumming up the filter.
Once the pathologist has that biopsy, they use something called the Oxford MESTC score to grade the damage. Let's translate this heavy pathology jargon into easy English so you know exactly what they're looking for. M stands for mesangial hypercellularity. Basically, there are way too many cells crowding the filter, which tells us the disease is likely to progress. E is endocapillary proliferation, meaning there's active inflammation inside the tiny blood vessels. And interestingly, this actually predicts the patient might respond pretty well to immune-suppressing drugs. S is segmental sclerosis, which is actual scarring of the filters, tightly correlating with how much protein is leaking. T is tubular atrophy. The kidney tubes are literally wasting away. Guys, this is the strongest predictor of long-term kidney failure. And finally, C stands for crescents, severe moon-shaped pockets of inflammation that are a huge red flag for a rapid decline in kidney function.
So taking those clinical lab findings and the MEST score together, what are our biggest red flags? Well, the number one warning sign is persistent protein in the urine over 1 gram per day. This is our strongest modifiable risk factor. Other major red flags include high blood pressure right at presentation and an already reduced kidney function, or eGFR, at the time of the biopsy. And we have to take these seriously, because despite our absolute best efforts, up to 40% of patients with this disease will reach end-stage kidney failure within 20 years.
Section 5. Conventional management. Let's look at the old playbook. Because of that severe 40% risk, let's see how we've traditionally fought back using the KDIGO 2021 guidelines. It's basically a step-by-step ladder. Step 1 is the absolute foundation for everyone. Optimized supportive care. We're talking strict blood pressure control, a low-sodium diet, and weight management. Step 2 is RAS blockade, using common blood pressure drugs like ACE inhibitors or ARBs. But we're not just lowering pressure here, we are specifically protecting the kidney filters from stress. Step 3, if that protein leak remains stubbornly high, is corticosteroids. But this is a tough call. Doctors have to carefully weigh the benefit of calming the kidneys against the serious risks of systemic infection. And step 4 includes optional add-ons like fish oil or even a tonsillectomy, though honestly, those have very limited or highly regional evidence, mainly practiced in Japan.
Which brings us to Section 6, the new treatment frontier. And this is where things get genuinely exciting.
We are finally moving well beyond basic supportive care. I want to read this quote directly from the latest updates because it is just thrilling. A paradigm shift is underway. Disease-specific, mechanism-targeted therapies are transforming IgN management. For decades, we only had generic tools like steroids. Now, we are entering an era of true precision medicine.
Let's look at these new game changers. First up is sparsentan, which gained FDA accelerated approval in 2023. It's an incredible dual-action drug that blocks 2 completely different destructive pathways at once, drastically reducing protein leaks compared to the old standard drugs. Then there's Neflicon, also known as Tarpeo. Remember how we said those abnormal antibodies are often produced in the gut mucosal system? Well, Neflicon is a specialized steroid capsule designed to bypass the rest of your body and release its medication straight into the lower gut. It literally stops the abnormal antibodies exactly at their source. It's brilliant. And finally, SGLT2 inhibitors, drugs like dapagliflozin. They were originally invented for diabetes, but we have recently proven they offer massive, incredible protection for IgA kidneys as well.
And this precision engineering goes even further with drugs targeting the immune system's complement cascade. Enter aptacopan, another brand new marvel. Instead of shutting down the whole immune system and hoping for the best, it acts like a molecular sniper. It specifically blocks the exact inflammatory pathway, the alternative complement pathway, that amplifies the kidney injury we saw back in our forehead hypothesis. It is an absolute masterpiece of targeted engineering. Which brings us to the ultimate question. We now have specific biomarkers, genetic profiles, and these incredible, highly targeted drugs like sparsentan and Nefficon. With personalized medicine finally on the horizon, are we truly entering an era where end-stage kidney disease from IgA nephropathy is just a thing of the past? It's a deeply provocative, hopeful question. And honestly, for the first time in medical history, the answer looks like it just might be yes. Thank you so much for joining me on this explainer today.